to present the case of heel gangrene. So that's a 68-year-old female patient presenting with this. As you can see, it's a patch of heel gangrene. She's diabetic. She has marked renal impairment, yet she's not on dialysis. Systemic examination was unremarkable. And examining her pulses, she had good femoral pulses and she had good popliteal pulses on both sides, but she had absent pedal pulses. She underwent a duplex scan, which showed a normal or no significant disease down to the popliteal artery, and all the disease was in the tibial arteries. She had a diseased anterior tibial artery, a diseased peroneal artery, and an occluded distal posterior tibial artery, which is not surprising given this lesion. Now I have a few questions. What would you do? And this is for the audience, if they like to share their opinions. Would you go for primary below knee amputation? Would you do a revascularization? And if you do a revascularization, would you choose angioplasty or bypass surgery? And if you choose revascularization, which first, the revascularization or the debridement?
Okay.
I'm going to stop here and let's just chat a little bit. Would you like to take over the discussion, Dr. Samer? Go ahead, please.
Yeah, let's get the fellow. Look at the fellow here. Me, Mana, Mohammed Dahman, you are there, right, Mohammed? I saw your name.
Yes, doctor, I'm there.
What do you think? You already saw the case. Mohammed Dahman is our third-year fellow. He's being graduate very soon. So he's our...
Doctor, I was in a call still a bit early here. So I was in a call on the phone. Just recap. He's a he's a male with a tissue gangrene.
Yeah, yes. She's 68-year-old female with diabetes mellitus and advanced renal impairment, but she's not on dialysis. And she's presenting with a patch of gangrene over the heel. She has a good arterial tree down to the popliteal artery. She has good popliteal pulse, but she has severe tibial artery disease. So where would you go from there?
So I'd like to know more history. How is she having any fever? If there is any more associated symptoms? She had this pain for how long? She had wrist pain. She had. I would like to elaborate more in the history. Then I will examine the batch itself, and I will apply the Wi-Fi criteria. Yes.
Yeah, very good questions. She has no systemic manifestations of infection. That is, she has no fever, no rigors, and she's systemically in a good shape. The gangrene is localized to the heel. The rest of the foot is okay. She has normal toes. The dorsal of the foot is okay. The leg is okay.
How is her functional status?
Very good.
She was walking before?
She walks around, yeah. Okay. She walks around. And regarding the pain, she's there is no pain because she has advanced peripheral neuropathy, sensory neuropathy, and she does not feel any pain.
Okay. So I would like to examine this batch. I want to see, and I would like to have ankle brachial index and toe pressure too.
Very good. Well, the ankle brachial index is over 1. It's like 1.3 or 1.3 because she has advanced calcification of tibial arteries, and the toe pressures are I can't remember the exact figure, but they're not reliable. Well, what we do in our center is the velocities, the ankle peak systolic velocities, and that this was very low, indicating severe ischemia.
Severe ischemia too. Okay, so she's a... Yes.
Before you go, man, I'll interrupt you for a second. Why you want to get to EBI? Why you want to do it? Why you want to know what's EBI?
Like for all patients, I know it will not be reliable in this patient. So I asked about the toe pressure, and it's not reliable in this patient. So I'd like to know how ischemic is the toe and how ischemic is the foot. Because the heel is not usually an arterial place. So I wanted to know if there is another factor. Most likely the neuropathy is another factor too.
But he has no distal pulses, right? On the exam, he mentioned that there's no distal pulses, only palpable pulses. So he has already tibial disease, you know? So we know. So do you think arterial duplex will give you any extra information you needed? I'm just questioning, just to the discussion.
Like an arterial duplex is a good if I want to target a segment in the angioplasty. So I want to know which artery is more patent down. Although the calcification it will not show in the CT scan, but sometimes in the ultrasound you can see a healthy segment that you want to target at distal.
Yeah, we did exactly this. We didn't do a CTA for two reasons, because she had advanced renal impairment, and because of the calcification as well. We actually don't like using CTA in patients who have solely tibial artery disease. So we did the duplex scan, and we have a very good quality duplex scan. We are lucky this way. She had patent anterior tibial artery down to the dorsalis pedis. She has a patent dorsalis pedis, plus it was very diseased. She also had a patent peroneal artery, but only proximally. The distal part of the peroneal artery was very diseased, nearly occluded. And the posterior tibial artery also, it was patent, but diseased proximally and then occluded distally. So if you're looking for an artery that's going down the foot, it's the anterior tibial artery that's going down the foot.
Anterior tibial artery, yes.
Yeah, but of course, the heel is the angiosome of the posterior tibial artery, which is occluded.
Okay. So still, I will go with debridement and angioplasty and give the patient the maximum I can.
Well, yeah, please go ahead.
Go ahead, sorry. No, go ahead, Dr. Shara, sorry.
So just for the sake of discussion, when would you go for primary amputation in a patient like, any similar patient? What would make you go? Go ahead.
Yes, if she showed manifestation of a sepsis, septic, and it failed trial of angioplasties despite maximum wound care, I think I'll go. But primary amputation in patient who didn't show any signs of sepsis, I would like to wait and to give her the maximum I can.
And as you mentioned during your questions, you asked about her functional status. So
yes,
if we have,
and she's very functional too. Yeah.
She's very functional. So if we have a patient that's bedridden and that's, is not using his legs, doesn't walk, well, we might go for primary amputation. I wouldn't agree with you that systemic infection would be contraindication to angioplasty, because this could be treated by debridement, IV antibiotics, etc. So you can get this under control and then do the angioplasty. What do you think, Dr. Samer?
I agree with that. The only thing, what time we did a study is long time ago, we found that if you have a heel ulcer in patients with diabetes and renal failure on dialysis, rarely they heal. So, but it has to be on dialysis. This patient not on dialysis is different. But this patient already on dialysis and diabetic and a heel ulcer, really the chance of healing is very, very low. So at least, I don't say you have to go with a primary amputation, but at least tell the patient ahead of time that the chance of healing is very low.
Yeah. So that's another reason. If the patient is on dialysis and has a deep heel ulcer, one has to think again whether to do primary amputation or angioplasty.
Yeah.
All right. I will show you the. There is another question, or actually two questions: angioplasty or bypass surgery, and if we're going to revascularize first or do the foot surgery first. So I'm going to stop again. So, Dr. Samer, would you like to ask one of the fellows to take over these questions?
All right, let's see who's here. We have Ahmed Muntin. Ahmed, what do you think?
Yes, if we follow the latest trials as the best CLI, for example, if we have a good vein, then a bypass surgery would be the way to go. Despite that, we don't have a posterior tibial, which is the target vessel for a heel, but still improving the inflow. If we have an arch, that would be sufficient, hopefully.
Okay. So what's your policy, Dr. Samer?
Yes, we follow the same things. I mean, I still like to do endovascular first, but if you don't go with the trials, always they said if you have a good vein. I mean, usually if you have only tibial disease, no, I prefer to go into vascular. But if I have like SFA, popliteal, and tibial, then I prefer to go with a bypass. But if I have a good SFA, good popliteal, just tibial disease, no, I think endovascular will work fine.
Yeah, this particular patient had a good popliteal pulse. So if we're going to do a bypass, it's going to be a short bypass from the popliteal down to the dorsalis pedis, or if the distal posterior tibial repeating down to the posterior tibial. However, in the great majority of our patients with disease confined to tibial arteries, we actually start with endovascular first, and the reason is our patients are in general are not good surgical patients. They are not fit patients, and they do badly with long incisions. So we reverse the surgery for a patient who has multiple level occlusions, like long SFA occlusion plus tibial artery disease occlusion, plus tibial artery disease, and good great saphenous vein, and also a good target vessel. And we identified a good target vessel using high quality duplex. So a patient with multi-level disease, good vein, good target, will go for surgery. But in a patient like this with disease limited to a tibials, I think we'll go for endovascular first, and we reverse surgery for if the endovascular fails. What do you think, Samer?
Let me ask Dr. Muhammad Rafat with us. He's still with us. Muhammad,
Yes,
you still with us?
Yes, I'm here.
What do you think?
So I agree. You know, if you go by best CLI trial, so they compared basically the two to endo and open, and the patients who were enrolled in the study, they were candidates for both. And candidates for open, in this case, you have to have a good target. You know, if you cannot do bypass on a bad posterior tibial area or anterior tibial area. So if the DP is good, then you know, you can bypass the DP. However, you know, also you have to think about wound closure and things like that. So in this case, I think it's reasonable to do endo because it's not occluded, you know, relatively easy to do, you know. So you just put a wire balloon it, you know, or do a atherectomy if you are believing in that. And this is an easy solution, you know, I think, you know, and you can do more than one level at the same time. So you can do the, you know, the posterior tibial, the anterior tibial, and if you can open the peroneal. So you can do that, you know. In this case, I think endo would be better. But if you, in general, the best CLI trial showed bypass is better when you meet the criteria for bypass. And I don't think this patient meets the criteria for bypass unless the DP is good and you can close the wound.
So how do you decide if the target vessel is good enough, Dr. Jaber?
So the size, you know, basically there's no, it's open basically. Some people talk about calcification. I personally think very calcified vessels are hard to bypass to. So, you know, they're very, very calcified. If the renal failure, very calcified vessels, I would not bypass to. But some people say calcification is no problems. So you have to have a good target, like a open vessel that relatively disease-free vessel. So that's a good target for bypass. And then if you do DP or plantar bypasses, you always have to keep in mind that can you close that wound and can you maintain it closed?
Let me ask you, Muhammad, I was in one meeting, and for me, desert foot is that nothing below the knee. But I was surprised that it's nothing below the ankle they consider desert foot. So this way they may consider desert foot, and they said it's good for deep venous arterialization.
Yes,
it's a good.
Yeah, deep venous arterialization is new. It actually was approved by the FDA recently, just a few days ago. It's you know, I don't do it, but people who do it, they have what 50% chance of saving leg on patients for 6-7 months, on patients who are you know, otherwise have no other options. The other thing also we forget, you know, functional status. So is it better to have a wound for a year and a half to heal, or just do a BKA and move on with your life? You know, also I offer the patient that, you know, because sometimes patient can have a BKA and can move on, you know, and can, you know, do well, or you know, that's another option you have to think about also. Or you're doing a TMA that's very high TMA or Shepard TMA, the functional status is not as good as BKA. So these patients,
especially with the heel ulcers, you know, this is a worse ulcer, you know. But again, I was surprised to see like these cases, because like this case, I'll do intervention angioplasty first. But I'm surprised I saw a couple of cases like this, and they went right away to deep vein arterialization because they said there's no arch in the, and they said you have to go right away. So I was just trying to see if, you know, they were a bunch of interventional radiologists, but you know, but anyway, all right. So Dr. Shara, what do you think? What did you do?
Okay, here is what we did. So we did a revascularization. That's I'll go just piece by piece. That's a carbon dioxide intervention, and what we just saw is the femoral artery. Oops. That's the proximal tibials, and these are the tibials. You can see it's going too fast. I'm just going to try and get it back a little bit. Here we go. You can see the anterior tibial, peroneal trunk, and the peroneal artery. That's carbon dioxide. That's why we don't see very clearly. And you can see the proximal posterior tibial. Oh, I'm sorry about this. But what I'm going to do with this, can you still see the screen?
Yes.
Yeah, all right. Okay, so that's the femoral artery. And that's the proximal leg.
Okay.
And that's the mid leg. You can just see the anterior tibial, the peroneal, and posterior tibial artery. They're all attenuated. And that's the distal leg, that's the ankle. There is no more posterior tibial artery. The peroneal artery stops here. And that's the anterior tibial artery, which is going down to the dorsalis pedis. And that's the foot. Now, what I did is angioplasty of the anterior tibial artery and the peroneal artery, because these were patent. So it was fairly easy. We went down with a 0.18 wire and a 3 millimeters long tibial balloon. That's the peroneal artery, and that's the anterior tibial artery. And that's going down to the dorsalis pedis. And now I want to do the posterior tibial artery. It couldn't be done from antegrade. So we went through the, sorry, through the pedal arch that's going through the dorsalis pedis artery and going all the way to the posterior tibial artery. Now,
what catheter? What catheter is this?
Okay, this is the CXI 2.6. That's Cook support catheter. Okay. So so that's the wire going all the way down to the dorsalis pedis and then plantar arch and then going up again. Once you have this, there are two options. Either you snare this wire into the sheath, usually there is sheath sitting into the popliteal artery, or you go down with another wire into the posterior tibial artery, and we chose this second option. So that's the second wire going down into the posterior tibial artery. Following
what kind
the same
of wire?
track. That's a 0.18 advantage wire. It's a Terumo. It's a Terumo company.
Glide wire. Yeah. 0.18 glide wire.
Yeah.
Gold advantage, they call it, I think.
So it goes all the way down to the lateral plantar artery. And then this was followed by, at first it was followed by the support catheter, which is the same CXI, and then followed by the 3 millimeters balloon. It's probably 2.5 millimeters balloon in the plantar. Here you go. That's a balloon. It's probably 2.5 millimeters balloon into the plantar artery and 3 millimeters into the tibial artery. And this was dilated all the way up. And these are the final images.
The CO2, huh? This one.
Yeah, that's CO2.
You didn't give
Yeah,
any
once you-
contrast?
No contrast at all, no. And that's down to the foot. Here, oh, I'm sorry about this. We'll go to the last image.
Because usually we give at least some contrast just to see the distal.
I'm sorry, we can't see the last image, but anyway, it's patent all the way down. So I'll stop here and ask for comments or questions if you like to lead the questions, Dr. Samer.
Okay, congratulations. It was very nice technique. This retrograde cannulations, you know, it's very nice. We do a CO2, but usually when it comes to the tibia, it's very hard to see. So we inject a little bit some contrast, just give us better view. It's only different we do it, but it's very nice. And after that, you debride. Did you debride the ulcer? How was the bleeding? Was good?
That's let me just take this. Here we go. And then I have these couple of questions. Sorry about this typo. Post-intervention treatment, what the fellows would think, and how would they manage this this patch of heel gangrene. So that's questions for the fellows. So what's the post-intervention treatment?
Who's it? Ahmed Umtin, you want to answer this one?
Yes, this wound, as in the picture, it needs some sort of debridement. It should be debrided, and then dressings has to be applied.
Okay.
Okay.
What about intervention? Ahmed?
Debridement is needed in this one.
What about after intervention?
Yeah, this patient, since post-angioplasty, I would keep him on dual antiplatelets. And in addition, if the patient is not on a statin, I will add, probably might increase the dose if he is already on.
Okay.
So of course, the dual pathway, we do this routinely. Regarding the wound, it's when we remove this patch of gangrene, the calcaneum was exposed. So what we do after 2 or 3 days following debridement, we use vacuum therapy to have some granulations. And then we, you know, after a month or so, we do skin graft. And she did very well.
Thank you very much. Very nice case. Rafa, do you want to add anything for the case?
Yeah,
would you done it differently?
I noticed, you know, they talk about bypass and miss. You know, the best CLI trial not only said bypass first if you have good you know, if you have a good candidate for bypass, but also they stated that endovascular also works very well. So in patients who don't have a good vein and good target, you know, endovascular is just as good as doing a graft bypass. So in this case, definitely, I think endovascular repair was the best thing to do. And the other thing is, if you have infected wound, you know, I usually debride this the day before and then do endo, because you know, if you have to pull a stent or you have to do something, it's better to get the infection under control and do it right away. And once you do the intervention, you don't wait, you know, a month or two to debride. You debride right away, because it doesn't heal. You know, these things shut off in about 3 months or so, usually. So these are the 3 points that I think fellows need to know, you know, in terms of CLI, you know. So
yeah, I agree. I mean, but for me, it just isolated tibial disease. I mean, it doesn't make sense to me to do a bypass, because again, within the vascular, you can target multiple level and you can do recanalization, as you see. I'm saying, I mean, the only time I really go right away to the bypass if you have an SFA and popliteal occlusion, or mainly popliteal occlusions, you know, and tibial disease. Then yes, I'm a something like that, just tibial disease. I still think endovascular is the best way because you can target 3-4 vessels, you know, can go more distal, you know, which you cannot achieve it with a bypass surgery unless you do a hybrid. But if you have an SFA popliteal occlusion, then yes, because patency is very low, and you know, so better to give them good bypass to the distal, and then maybe later on you can do more through the graft if you want to do more distal, like you know, hybrid repair. So this is my I do, you know, look, because this trial they don't talk. There's a lot of variation. They don't talk specific how much, you know, which one is involved, which one disease is popliteal, SFA, tibial, you know.
Okay.
They just talk in general, you know. But this is the way I look at that. Okay, great. Any question from the fellow about the case? Or anybody, guys, on us?
Ahmed is raising his
Yeah.
hand.
The only thing that I was concerned about is that we only have a single runoff vessel. And if that vessel was dissected with an endovascular, then we're done. We don't have any other option.
Really, it's not concerned anymore. I don't know why. We used to think a lot about that. It is difficult and you may lose it and then you lose the legs. But now, I think if you are expert and with a good technique, really you get to these issues, you know. So it's never been a problem for me, just single run off. I still do them, even single run off, yeah. I know what Shara and Muhammad think.
Well, I think I agree with you. And also, you know, let's say, you know, dissect that. You can always do bypass to the DP if you're really in trouble. But this is a diseased vessel. This is not a healthy vessel. That's number one. The only time you shouldn't do a vessel like that if you have a patient with claudication. You know, I have a patient who walks about a block and he has a single vessel runoff and like that. I didn't do anything with that patient because you can, you know, you can get them in trouble. But if you have a critical limb and you know, you heal ulcer and either that or you amputate, you know, I would do it. And I just, you have to be very careful, you know. So we're doing endovascular. So like Dr. You know, he did 018 wires. You know, you don't use 034 wires there. Oh, I'm sorry, or 035 wires, the big wires, or you don't. You have to be very gentle. You know, either 014 or 018 wires for these vessels. You know, you have to treat them with respect. So.
All right, Dr. Bishara, any last word about the case?
No, thank you very much. It's been a pleasure really being with you. I'm sorry I have to leave you at this point, but thank you very much for inviting me.
Thank you. Thank you. Nice case.
Bye.
All right, guys. Let me present guys of case from the book, not from me.
Dr. Samer, Dr. Rashad. Excuse me. I'm Mustafa Bhiri. Can I ask about the wound? What's your expertise for prognosis of this wound?
Prognosis of this one?
This wound.
This one, the prognosis. As I told you before, I mean, heel ulcer is bad prognosis anyway, you know, in general, heel ulcers, you know, because not much muscle. You see skin, fat, and then bone, you know. So this is a problem with the heel ulcers, different from any part. So this is the heel is the least vascularity part of your foot. And so whatever you do, I mean, it's difficult to heal. So again, if you have patient on dialysis and diabetic and like severe disease, tibial disease, maybe sometimes primary amputation is not a bad option, you know. But you try your best, you know. But in general, heel ulcer is a bad prognosis.
And can I ask you and Dr. Rashad any precaution for dealing with this heel wounds?
Say that again.
Any precaution for dealing with this wound?
I mean, the most important is the pressure. You have to take off the pressures, you know, because they keep walking on it, and because part of this is, you know, neurogenic ulcer. This one because of the, you know, sitting on it or walking on it, you know, especially the heel area. So you have to use, you know, total cast, you know, or to use like offloading, use a foam boot or something like that to take the pressure from the ulcer. Because if you keep the foot normal on the bed, this is what would cause pressure. This ulcer will not heal. So you have to use a kind of offloading for this ulcer. Muhammad, you want to add something?
Oh, I agree. You know, this the main thing is like offloading, and even then, you know, that's may not work very well. And do the intervention right away. Don't wait too long to do it. So.
All right, so let's go down to the book, to the real life. Let's go. We have half an hour. Muhammad Aman, you want to take the case, Muhammad? Let's, because we're doing cases.
Yes. So a case report, 72 years old, non-smoking female with past medical history of hypertension, well-controlled diabetes and stable coronary disease status post-CABG with bilateral great saphenous vein harvest. Present to her podiatrist, she developed an ulcer on the right first metatarsal head after wearing a new pair of shoes approximately 4 months ago. The wound is gradually getting larger despite appropriate local wound care and offloading procedure. She's referred to you for evaluation for arterial insufficiency. Physical examination revealed normal and equal bilateral femoral pulses with no distal pulses. There are healed bilateral medial thigh incision. The toes are pink with breast capillary refill. There is diminished sensation to fine touch bilaterally, but normal motor function is noted. The ulcer base is pale with fibrous debris. There is no foul odor or obvious cellulitis.
Okay, so this patient 72 is an ulcer, and maybe she has a vascular.
Minor tissue ulcer with CLTI, maybe. The best first step in her evaluation and or management, it will be A, operative debridement to eliminate the necrotic tissue and the bone initiation. Oral antibiotic post in the culture result. I think they did already local wound care. B, lower extremity arterial Doppler with waveforms. Okay, this is a good answer. C, MRA with lower extremity. D, angiography with possible intervention. E is the start collectazole and walking program. So the first step is also diagnosis and evaluation. I think I will go with B, doctor.
Because they need the first step. Okay, all of them. You can do MRA angiogram, the first step, you know?
Yeah, yes.
Okay. What's the difference between MRA and angiogram? Which one better for the TBL?
Like CT angiogram depends on the contrast that's reaching there, so usually it's not good. MRA can give you better for the TBL disease. The best one is angiography.
Correct, but MRA is better than angiogram, CT angiogram
Yes.
for TBL.
Yes.
What's the problem with MRA? What could happen? What's the side effect of MRA? You have to worry about CT angiogram. We know the contrast, but MRA, what we worry about?
So usually the gadolinium is nephrotoxic, but less nephrotoxic than CTA contrast, and the long procedure, it takes 30 minutes, and the metallic. So maybe she has some metallic.
What get from the gadolinium? Called nephrotic what syndrome?
ATN,
you know?
acute cerebral necrosis they get. And nephrotic, yeah.
No, systemic fibrosis.
Okay, sorry.
Right. Systemic fibrosis. Have you ever seen it?
No, actually, no.
Never seen it in my life until last week. I had one of the VIP patients. She's young, and she has an MRA. And I was surprised to see. I mean, she has a extensive tissue, subcutaneous skin, muscle fibrosis. She became disabled. She cannot even walk. So it's really the first time I see this nephrogenic systemic fibrosis. I just read about it, but it's the first case I saw last week. One of the top VIP patients, and she had an MRA, and boom. And she's very educated, so she knows that. She told me I'm a very rare case of. You can see her; she cannot, straighten her legs because of fibrosis. So it become like, wheelchair bounded. So you have to be careful with the guys. Muhammad, have you ever seen cases like that?
No, I have never. I just This is the first time actually I hear about one, even your case.
Yeah,
Yeah.
the one who told me, because I get educated. She went to France. I mean, she's she's a VIP, so she went to France, United States. She knows that she's been treated many times, so she knows what's going on. She told me I am one of the cases. She has nephrotic, and you can see her. I mean, really, it's the first time I see that. I mean, she cannot stand because the fibrosis affect. She told me before that I was fine, and then she cannot because severe fibrosis affect her muscle, skin. Sometimes involve lung, liver, sometimes myocardium. Sometimes could be fatal, really. So very, very rare, of course, but just keep it in your mind. Nothing in medicine is 100% safe. Just be careful, guys. Okay. All right. So MRCS. Sorry.
I'm sorry, may I ask, what was her baseline GFR?
I don't remember, but most probably it's low because happen only when the GFR is low. Less than 30%, I think. There's a time where you see it, where there's a risk. If the GFR more than 30, the risk is low. But when the GFR is low, and then they do MRA because they want to avoid, kidney nephrotoxicity, so good happens. So just keep it in your mind. I just mentioned that because I just saw it last week, first time in my life. Okay, any question about this one? No. Well, let's go to question 2. Who's with us? Osama. You want to take Osama?
Yes, Dr. Samer.
Go ahead.
Which of the following is true? A, ABI correlate with well with long-term survival in peripheral arterial patients, peripheral arterial disease patients.
Let's one by one, Ahmed. Osama. ABI correlate well with the long-term survival in PAD patients. Correct or is wrong, you think?
It's the right answer because in patients with highly calcified arteries, maybe we get a wrong reading of ABIs.
No, what I'm saying is that when you have a low EBI, right? What does that mean? That means you have vascular disease, correct?
Yes.
And vascular disease is a tree. It's not only in the legs. So when you have vascular disease in the legs, what does that mean? Most of you have a coronary artery disease. Most of you have a carotid disease. Most of you have a renal disease, correct?
Yes.
Because all the low EBI, it's also indicator for long-term survival. So people who has a low EBI, the long-term survival is much lower than normal patients. So the reason why some people we do an EBI, not because patient asymptomatic, not because we want to discover it and treat them, because we know of the high risk for coronary artery disease and all other problem are carotid disease, which may increase their mortality. So we can interfere early and improve their surveillance. The reason why, if you go with a guideline, they said you have to do like routine EBI on patient like maybe above 50 or 60, not to discover arterial disease and fix it, to discover that he's high risk for coronary artery disease and try to fix it early before it hit and then lose the patient. You get the point? So yes, EBI, it's very well indicator with the long-term survival in PAD patient.
Can I ask a question regarding this point? In case of patient has highly calcified vessels and the ABI become high more than 1.2, 1.3, so it can be correlated with the survival, long-term survival?
If it's high, that means the false signal. You have to go to DBI, and then depending on what's DBI. If DBI is low, then yes, it will correlate it, So EBI is correlated, yes, if it is normal, if it is real, it's not like a false elevated. So if EBI like 1.2, 1.3, this is wrong. So you cannot say no. What I'm saying is non-calcified artery. You get the point?
Yes.
Okay. So EBI correlated well with the long-term, yes, because you talk in general. You're not talking about calcified artery, because the calcified artery is not an EBI. It's a false. It's not ABI. You cannot even call it EBI. It's a false study. You see my point?
Okay. Yes.
Yeah.
So
go ahead. Next one.
Next one. B. DBIs are unreliable measure for peripheral arterial disease in diabetic patients due to small vessel calcification.
You know what DBI? DBI is a digital, correct? So when the EBI is too high, calcified artery, usually we do DBI because rarely you see calcification in small vessels. That's why we go to DBI. So when patient has a calcified arteries and elevated false elevated EBI, then we do DBI. So DBI is reliable usually. You know, the reason why we do it, we have a classifications. So this is wrong, correct?
Yes. So I'll go to C, a direct popliteal artery pressure measurement for greater than 50 mmHg helps to predict positive outcome after angioplasty.
Okay. I'll tell you is popliteal artery pressure. Maybe it's difficult, guys, for you. I'm telling you the popliteal artery pressure measurement, you know, what the pressure in popliteal artery. Help you predict positive outcome after angioplasty. What kind of angioplasty? You see, this question, if you look at without knowing the answer is wrong, because what kind of angioplasty? They are talking about SFA, popliteal, velocity. You see? So when you read this one, even if you don't know answer, it's just the way they put the question is wrong, you know. So this should be by default is wrong, you know. But popliteal artery usually is important for us to forward for balloon amputation to know if it's going to heal or not, you know. So usually people, they use the popliteal artery pressure measurement to predict if balloon is going to heal or not. One of the measurements, of course. But angioplasty like that, without mentioning where is angioplasty, I think this is a wrong answer would be. All right?
Yes. So
You follow me?
Yes, Dr. Samer. So you go to D, pulses TARDIS waveform on the lower extremity arterial duplex examination correlate with adequate arterial perfusion.
Okay. Of course, going to ask what is that pulsus TARDIS. Guys, you get this question in the exam. I mean, yeah, you know what is that?
Pulsus TARDIS, it means abnormal waveforms to indicate diseased vessels.
Correct, 100% correct. So pulsus TARDIS mean you have an obstruction proximal or severe stenosis because the low flow, you know. So when you have it, that means you have a diminished disease. You have a low perfusion, not adequate perfusion. So this is wrong. Correct?
Yeah.
You know what pulses mean? TARDIS, where does it came from? It's a Latin word. Pulses that mean weak. TARDIS means slow, so weak and slow. So it's like a monophasic. You see, away from like monophasic. It's like very, very similar to monophasic. So if you have a monophasic, that means you have, you know, non-adequate blood arterial perfusion, correct?
Yes.
All right. Any question about this question? Rafa, do you want to add something?
No, not really. I mean, it's all said very well.
Yeah. All right, so let's continue. Who was? Maitham, you want to continue, Maitham?
Yes, Dr. Samer.
Yeah, please continue.
So
an
aortogram with runoff was performed via left femoral artery and showed a normal aortoiliac segment with the 20 cm left SFA occlusion and diffuse tibial stenosis with continuous flow into the foot. The right SFA showed 3 areas of focal stenosis with proximal and mid lesions measuring 1 cm and the distal measuring 2 cm in length.
Okay. So let's see it here. This is angiogram on the right leg. You have a stenosis here, 1 centimeter. Here, stenosis. Here, stenosis. Okay. This is SFA. This is PTL below the knee. This is anterior tibial. The posterior tibial is occluded, peroneal is open, and then it's occluded. So you have to run off through the anterior tibial, right? Yeah. You see the images? Is it clear?
Okay.
So you have 3 stenosis in the SFA, okay, and you have peroneal is occluded, distal, posterior is occluded, and you see multiple stenosis or small stenosis in the anterior tibial, very mild stenosis, you know. I don't know if we have below. We have below the knee. Here, distal, anterior tibial. You can see stenosis, and this is ankle, and you don't see dorsal artery. So we only have this single run off to the foot. Okay. The ulcer on the dorsum of the foot, right? Let's see. Let's go back to the question. Where was the ulcer? first metatarsal head after wearing a neurodevelopmental ulcer. First metatarsal head. Okay. So this is mainly posterior tibial and anterior tibial area. All right, let's go to the question now. So you saw the angiogram. You can continue, the most distal lesion and
the most distal lesion ended proximal to the adductor canal. The popliteal artery had no significant stenosis. The right posterior tibial and peroneal arteries were totally occluded and didn't provide any collateral flow into the foot. The anterior tibial had several areas of distal stenosis, all proximal to the ankle. The most severe was just above the ankle joint. There was no complete pedal arch, but abundant collateral flow in the foot was present.
Okay. So the same what we saw in the angiogram. So what's your question? I'm talking about task.
So the task, transatlantic societal classification category of the superficial femoral artery segment is best identified as.
Remember what that is? Oh, we need to renew that. That one, because guys, you get these questions at exam. You have to read about task and you have to know about them, Task A, not only you, anybody can answer, guys. Anybody know task A?
Usually a single stenosis in task A, but this looks like task B.
Well, let's go one by one. Let's see what task A is. So task A is, you said single stenosis?
Stenosis less than 10 centimeter or occlusion around less than 5 centimeter.
Correct. This is task A. What about task B?
Task B, when there is multiple lesions, each one usually short, less than 5.
Correct, yeah.
When there will be a single stenosis, less than 15 cm.
Correct, that's good, guys. Good, I'm good. So this is B. C?
C, as I remember, if it's more than 15 cm.
Yeah, because last time I went to 15, so it has to be more than 15. And the last one, D and D?
D, when it is long, very long, or if stenosis, or if there is occlusion of the SFA. More than 20. Yeah, that's one is 15. This is 20. Yeah,
that's correct. What about E?
There is no E.
I have no E. I have no idea. There is no E.
That's correct. There's no E. They just would confuse you. All right. So what is this one now?
This it's gonna be B. Task B.
It's multiple small one, so this is must be B. What? Okay, let's see about treatment. What task A? What's the treatment for task A?
Task A is endovascular treatment.
Correct. What about B?
And B, it can be both, but more preferably for the endo.
C?
C, also the same, but more preferable the open. And
correct.
D is the open.
That's good, guys. You're reading good exam. When's your exam?
Our exam or the...
Getting close, huh?
Yeah, close.
Good. All right. Well, let's. We already answered this one, but let's go through it. My time. You can continue.
Okay. Question number 4. The best treatment option for this patient is. Let's go one by one. A, medical management with solistazole, clopidogrel, and referral to a wound care center. There is multiple stenosis and occlusion, and patient has tissue loss. It will not go. It will be not enough the medical management for this patient. Needs to have a good outflow for tissue healing.
Correct. So it's wrong. Next one.
B, percutaneous revascularization of the femoral lesion with distal synthetic popliteal to anterior tibial bypass at the ankle. Well, percutaneous revascularization of the femoral artery, that's okay, but distal synthetic popliteal to anterior tibial bypass, it's better if we are gonna doing a distal bypass to use a vein, not a synthetic one. And
the second lesion. Why need to do bypass for VTL? VTL is patent. So this is, you know.
Yeah.
The second thing, as you said, is a stenosis. If you have to do, would be vein, not synthetic. So this is wrong. I mean, this one all wrong. Next one.
C. Percutaneous revascularization of the femoral and anterior tibial arteries. Yeah, this is correct one also. Anterior tibial has multiple stenosis and can be done percutaneously with angioplasty alone. D. Right femoral to anterior tibial composite bypass graft. Well, for task B lesion with this one, I think it's
too much.
Too much, yeah.
In general, composite bypass graft is very nice to use it really. You see all this trial, they show you have a good vein. If you don't have a good vein, they want you to go to the vascular. Composite graft, I mean, maybe Muhammad can elaborate on that. It's very bad, you know, graft. You know, I prefer endovascular than use composite graft. Muhammad, what do you think, Muhammad?
I totally agree. I think, you know, if you don't have a perfect vein, perfect target, bypass is not worth doing because it will go down and it can cause the patient more morbidity. And if it goes down, you know, you increase the risk of amputation at this point too, you know. So if you're good with endo, that's why the best CLI trials, they recommend you as a vascular surgeon to be good with, not only with bypass, but also with open, and choose the best option for the patient. And I think, you know, if you can do things endovascularly and safe, you should do them, you know. So unless you have very long occlusion, like SFA occlusion, very long, I would do bypass if I have a good vein. If I don't, I would do endo.
Cool. Muhammad Dahman, what's the difference between, you know, bypass and endovascular if both came down? Why is that open always work or the same? Get my question?
Not actually. Like, what is the difference between the patency in endovascular and open?
You do a distal bypass. Patient has SFA popliteal occlusion.
Okay.
And you do common femoral popliteal below the knee or tibial bypass with the vein. Okay?
Okay.
One patient. Second patient is same as SFA popliteal occlusion, and you go do endovascular. You go there, you recannulate SFA popliteal and you stent them. Okay? Let's 2 months back, later on, they come both with occlusion. Do you think they represent the same or is different?
No, they present different, depend on the collateral in each cases. So
which one represents?
So the vein patient will be less mild in symptoms, because if the stent is thrombosed, it will close the whole collateral, so he will come to you earlier. But the vein patient, usually, if they stick to their medication, sometimes they occlude without symptoms even.
So I get confused now. So which one has come worse? The bypass or the endovascular?
The stent. The stent.
I think the bypass, unless the stent is covered stent.
No, it's uncovered stent.
Okay,
so uncovered stent. Yes, uncovered stent. Really, we use covered stent. I can say why not. So you do endovascular, both, and let's say 2 months, they came to the ER with obstruction. One he thrombosed his femdistal bypass, one he thrombosed his stents. Which one you think has more critical limb ischemia, the bypass patient or the endovascular patient?
The bypass, maybe. I think bypass.
Endovascular. If he thrombosed the endovascular, he will be worse.
Ahmad, he said the bypass, so 50-50.
I think the bypass.
Okay, guys, no, it's a bypass. And the reason why, guys, you see, when you do a bypass, the blood flow go from the low resistance. The blood, when he got choice to go between low to high resistance. SFA occlusion, you know, then he will go through the graft, you know. So any segment open after the bypass will occlude it, because, again, the blood will go through low resistance. So what will happen when you do a fempop or femdistal bypass, all the collaterals, they will be closed because you have a good flow now, with beautiful flow to the foot. And the second thing, when they thrombose, most of the time they thrombose suddenly, you know, so you don't have time to reopen the collateral. So in general, when they come to the ER, they come with acute limb ischemia. Whereas a stent, when they occlude gradually, you know, slowly they build up an intima, so the collateral will open up in the meantime. And sometimes not all of them occlude, only a segment will be occluded. So usually when they present in less acute stage than when you do a bypass. And the reason why you have to be careful about bypass, because stent, when they occlude, you may go back where you start, but the femdistal bypass, when they occlude, they go like step behind where you start. You don't go where you start, you go like one step back where you start. This is my experience, but I'd like to hear from Muhammad if he has different opinion.
No, I agree with you. I think bypass go, what they say here in the US, they say they go down hard. So, you know,
yeah,
the risk of amputation is very high in these patients, you know, usually if you're not on it. And especially if you have outflow issues or vein issues, you know, these are not correctable. If it's a technical issue, you know, usually patients do okay. But if it's not a technical issue and it's an outflow issue and a vein issue, these patients are almost heading towards amputation. The covered stent, I think, so it goes down hard too, but the bare metal stent doesn't go as bad, usually, like Dr. Samer said. So
I agree with that. And the reason why, if you look at the study, he said, you know, that covered stent like Viabahn, patency is better than bare metal stent, better than balloon angioplasty. But I don't like to use it in SFA because first the size, it's like so bulky. And second, when they thrombose, as I said, they come like a fem-pop occlusion, they come acute ischemia. So the reason why I don't like to use them, you know, even though beta C is better, but I don't want to take a chance because they close all the collaterals, you know. So when they thrombose, the whole thing thrombose like a fem-pop bypass. Whereas a stent, when they close, the collateral usually is still there. So you can still see collateral coming out. So I don't use Viabahn, really I use an SFA, unless it's aneurysm. But for disease, I don't know, Muhammad, if you use it, I really use Viabahn, you know.
I don't use stents, period, unless I have to, you know, usually.
Yeah,
because
to avoid. I think the best treatment for us, SFA is bad arteries, you know. How many power work on the SFA, guys? You know that? How many, what type of powers work on the SFA? We have 4 kind of powers. Do you know, anybody knows? We have compression, tension, torsion, and extension. So all this work. So whatever you put in SFA, it has to take all this, you know, forces. You know? So it's very difficult to get an excellent stent to can stand all these forces. The reason why whatever you do in SFA doesn't work. In my opinion, I think the best treatment for SFA, at least now, is debulking and drug-coated balloon. I think this both combination, I think maybe give you the best outcome for SFA. What do you think, Muhammad?
Yes, I agree. You know, because if you yeah, and then selectively, if you have to stent, you stent selectively. You don't just put if you have a dissection that's flow limited in one area, you stent only that area. And now I don't know if you guys have these, Dr. Samer, the TAC like a stents, you know, the dissection stents for the SFA, you know, Schneider. And we use these now, you know, for local dissections. It's like a small stent, you know. They're available here.
This is the one, the multi-stent, like 6 of them, small one.
Yeah,
this is the one you talk about.
Yeah.
It comes like 6 the same. You play one by one.
Yeah, by Phillips, you know. So and yeah, that's what it is. It's just a small stent, you know, that you stent that focal area. So
did you use them now, or you've been using it for a while?
Oh, really? I've used it only maybe a couple of times. I usually, if I have an unflow limited dissection, I leave it alone. But if you have a flow limited dissection and I have to stent, I use these now. So.
Right. Yeah. All right. Running late. Let's go to the last question. I think here. Who's there? Saeed, you are here. I think I saw Saeed. Is Saeed here? No, it's not here. Osama, you want to take this one, Osama?
Yes, I can. Okay.
Let's finish. Yeah. Can you read it?
Yes. The question or the discussion?
this is a discussion or a question? Discussion, right femoral artery discussion. Is there any question or are we done? I think still one question. They just tell you what they did. Yeah, there's a question here.
Five.
Oh, let's go back. Sorry. Let's go back, see what they did. Just tell you what they did, I think. They can go very quick.
Okay. Discussion with the patient occurred procedurally in the office setting. She was offered concomitant intervention if deemed appropriate. At the time of informed consent was obtained. The patient was given appropriate sedation and anticoagulated with heparin. Diagnostic 5 French sheath was exchanged for 6 French. RDC angled gliding sheath. Cannulation of the contralateral common iliac was performed with the aid of SOS catheter and 0.035 stiff hydrophilic guide wire under constant fluoroscopic guidance. This was advanced to the right external iliac artery. Roadmap techniques and small amounts of contrast were used to cross the SFA. I think, could we continue to the discussion?
Sorry. Yeah, here.
So they explained the procedure, what they did. I think
can you read it?
Yes, an angled coated 5 French catheter was employed to assist the crossing of the stenosis. The tip of the glide wire was placed in the distal popliteal artery. A 5 millimeter by 4 centimeter preoplasty balloon was inflated at each disease area with adequate angiographic appearance and no evidence of dissection or other complications. Next, the 0.035 guide wire was exchanged for 14 exchange length guide wire, and the lesions in the anterior tibial artery were crossed. The stenosis was treated with 2.5 millimeter by 5 centimeter balloon with good result and no complications. The sheath was partially withdrawn and the left femoral artery was imaged. The access site was felt to be adequate for arterial closure device, which was placed without complication. The heparin was not reversed. Following the treatment, her post-procedure anterior tibial ankle waveform was multiphasic. Her ulcer improved with the reduction in diameter. However, the first metatarsal head was exposed. The patient underwent right first transmetatarsal amputation 2 weeks later, which healed nicely. 6 months later, routine lower.
Sorry, this is angioplasty.
Yes, so they did angioplasty with balloon 2.5 over 5 centimeter of the anterior tibial artery. So the lower extremity arterial non-invasive testing showed the flat right ankle PFR. The patient denied new ulceration or pain. So in conclusion, the patient, she underwent angioplasty of the anterior tibial artery with balloon angioplasty. Yes.
So what your answer would be?
The question, the patient should be offered an intervention if anatomically appropriate. I don't think this is the right answer because now currently the patient, she has no new ulceration or wrist pain. So I don't think she will get benefit from re-intervention. Operative revascularization.
Okay.
Also,
so
she has.
Ulcer is healed, right? I mean, it's healing, right?
Yes.
And the right amputation was healed nicely. So the ulcer already healed, okay?
Yes.
So the duplex showed flat right ankle. So that means re-occluded of the artery or restenosis, correct? So now you have a restenosis below angioplasty. So but the ulcer already healed and she has no new ulcer, no wrist pain. So do you have to repeat angiogram, revascularization, should do a distal bypass or just risk modification? This is our question. So they're telling you that stenosis is back again, but she has no ulcer, no wrist pain. So let's start one by one. Repeat angiogram and intervention. Do you need to do it again? Hello, somebody are with us?
Yes, Dr. Samer, we hear you.
Can you answer?
I think Samer cut off. He's not here anymore.
Sorry, I think there's my connection. You want me to continue, Dr. Samer, or Maitham should continue?
Doesn't matter. Any of you guys. So Maitham, can you answer Maitham?
Can I answer?
Yes, Dr. Samer.
Yeah, please, can you answer?
Yeah, so now the patient is have a wound which is healed nicely, and he doesn't have any new ulcers or wrist pain. So so repeating angio and intervention will not solve anything yet. So we are not dealing with any wrist pain, or we are not dealing with the tissue loss for healing. So we just need to address his risk factor, okay, and control it, and lifestyle modification and protective measures for the foot and foot care.
Okay. Do you need to give any warfarin?
No need for that. No need for warfarin.
Warfarin. Okay. Okay, so it's very, I mean, well, the whole idea is they want to tell you that even if you got restenosis, as far as ulcers already healed, you don't have to worry about it. As Mohammed mentioned, this usually angioplasty, especially for the tibial, is like if they are calcified, they don't last more than 3 to 6 months, but it's enough for the ulcer to heal. So as far as your ulcers healed, even if they came back with the restenosis, we don't do anything for them, okay?
When you say risk factor modifications, what is that? Do you guys know what is that? So if Dr. Samer is okay, I can tell them a little bit quickly. So think of a vascular patient, it's a systemic disease patient. So think of him like heart patient. So these medications should be on statin with LDL goal of less than 70. Should be on antiplatelet antitherapy, whether aspirin or Plavix. Plavix is better, but then Plavix has 30% non-responders. So I don't know if you check for that or just do aspirin. The dose of aspirin does not matter, 81 or 320 to 325 here in the US. I know in the Middle East are different, but you can do low dose of aspirin is okay. And then orthotics, meaning, protective. I don't know if you have podiatrists there. Absolutely, they need to have a podiatry follow-up or somebody who take care of their nails, take care of their, feet, and have protective shoes, basically. But think about these. At least every vascular patient should have a statin and should have aspirin, unless there's contraindications, and feet protection. These are the hallmark of treatment of peripheral vascular disease patients, whether CLI or not.
I agree with that, Mohammed. It's well said. Any question from any of the fellows? Any question about the whole scenario today or the both cases? Any questions? This is usually you're going to get an exam, something like that. And you can see, this is a normal, it's not like a tricky question. Exam, don't think they're tricky on the exam. The whole idea to give you just a real life scenario. Just try to respond like what you do normally in your clinic, So everything is simple, just straightforward. Don't think that they're tricking you with any questions, All right, thank you very much. And really appreciate Dr. Muhammad Rafat with us today. And Dr. Bishara was with us today. So thank you, everyone. And we'll see you next week. Take care. Bye-bye.
Have a good day.
Thank you, doctors.
Thank you. Bye-bye. Thank you.